It's me. Okay, so hoping your Wednesday is going well because it's Wellness Wednesday. All right. um, as promised, I'm going to carry on here with a little YouTube video that will go through what we did not quite get to. Okay. I've also put together, for your pleasure, a um, review session. Okay, that will be on top of what Maria does. Okay, students always want a study guide, so we have put together a study guide as well. All right. Okay. So we were just starting Afib. Again, 10 million people in the U.S. have Afib, so it's a big deal. You know, it's a large percentage of the strokes you're going to deal with have to do with Afib, and so it's something that you're going to have to manage. Okay. I'm going to say this a couple times. You start conservatively with drugs. Okay. Right. Rhythm control in combination with anti-clot therapy, which is platelets. Okay, antiplatelet aggregation and anticoagulants. Okay, we also saw that we can do cardioversion. Okay, when these kind of therapies aren't working, and this can be one of the first things you do too. Okay, depending if you're having a very acute a case of AFib, where you have hypotension, you're passing out. Okay, so your blood pressure just drops. All right. You can do hotspot ablation, and then the worst case scenario, you can actually destroy the AV node. Okay. All right. So let's continue on with this process here. Go on to the next slide. Okay. All right. So this is a model. Okay, that shows you the flow of electricity in blue. Okay. So you have your sinoatrial nodes up here, and it discharges. You see it right there, and sends electricity across the atria. All of your cardiac muscle is electrically coupled, okay, which means that when one discharges, the other one discharges almost simultaneously, because you want to have a uniform contraction that gives you a uniform rhythm of boom, 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 okay? That electricity, it's an action potential generated by the sinoatrial node, flows across the surface of the atrium, and then it activates the atrioventricular node. And then that sends the electric wave all across the ventricles right here, okay? And again, the idea is to have a really clean rhythm of bump, 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 not a bump, 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 okay? All righty. All right, so that's the model that works. Okay, we watched this video last time. This is another video right here that we can watch. It shows you again the concept of how clots form, and it simplifies it in terms of anticoagulant therapy. But there's much more. You're going to do, like I said, rate, rhythm, anti-clot therapy, which is a combination of coagulation and platelet. Okay, let's take a look at this video right here.
The main risk associated with AF is stroke. People with AF are 5 times more likely to have a stroke compared with people who do not have AF. As the blood is not being properly pumped away from the heart, it may collect or pool. Where this happens, a clot could develop. A blood clot that forms the...
And that's regurgitation. The blood just kind of forms these little eddies, okay? And then that pooling triggers the whole clotting response.
This way can leave the heart and travel through the arterial system directly into the brain. As the blood vessels branch out, the clot may reach a point where it becomes too large for the vessel and effectively blocks it. This causes the surrounding area of the brain to be starved of oxygen normally delivered by the blood. Eventually, this causes the nerve cells to stop working and die. This is called an ischemic stroke and can affect large areas of the brain. Anticoagulants are commonly prescribed because they help
antiplatelets as well.
Increase the time it takes your blood to clot, thereby reducing the risk of stroke. Ask your doctor for further information on available treatments to help prevent blood clotting and stroke.
Awesome. We will. You guys are the doctors. What are we talking about here? Okay. Next. All right. So we're going to continue on with our little mission here. All right. Okay. So like I said, okay, what do? We start conservatively and we get more aggressive, okay? So we need to control things, right? Right here, we're going to control the rate and rhythm, and we're going to control the clotting. There is a kind of a hierarchy. This is just one example here. You can have this persistent AFib, okay? You actually feel it. The people that have AFib says it feels like a fish flopping around in their chest, okay? And that's because you don't have bump, 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 bump. It's bump, 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 bump like that. And it's all that's the rhythm, and the rate is can be like that. So it's just not normal. It can come out of nowhere, and this is the paroxysmal one right here. Okay, and your treatment is, do people become hypotensive? Do they pass out? Do they faint? Do they have heart pain because the blood is not being pumped adequately into the coronary arteries? Okay, that can lead to heart failure as well. The muscle will die off. All right. So you're going to be giving anticoagulant therapy initially until you figure things out. Okay, then it's going to lead to other things. We're going to show the ablation surgeries that is commonly used for paroxysmal AFib. You can have somebody that's had this for years. Okay, and it just you're going to model it. You're going to give them anticoagulant, rate control. You may give them rhythm control drugs, okay, give them cardioversion. So these are all the different approaches that you'll be using in your clinic, okay? Alrighty, so here's the Mayo Clinic telling us straight up, okay? What are you going to do? You're gonna take control of this. You're going to reset the rhythm, and control the rate, and you're going to prevent blood clots with anticoagulants and antiplatelet aggregation therapy. Right, I want to show you this paper right here. It's actually a good paper. Again, it shows you the kind of strategy that you guys are going to be using as internal medicine docs or as cardiologists. Okay, and making this decision. Am I going to do rate or rhythm control in managing this patient that has AFib? I'm talking 10 million people, so there's a good chance that you guys are going to be dealing with these kinds of patients. And so again, it looks through the different categories, okay? Just like everything else we've done in this class, we categorize, Remember when we just got done with controlling blood cholesterol, we were categorizing. Do you have elevated cholesterol? Do you have elevated triglycerides, okay? What are your LDL like? What's your total cholesterol? All these kind of categorizations, okay? And we had that Fredrickson's categorization that we went through 1 through 5, okay? Here's another categorization that you'll be using, okay? You're going to look at associated causes, and there's lots of different causes right here, okay? That you'll be doing diagnostics on to figure out, okay? And then I want to get down to this concept then of, what are you going to do? So you have your rate controlled drug therapies, okay? Is there evidence of heart disease? Okay, heart disease meaning the actual cardiac myocytes have died off. Coronary artery disease, that means you have massive atherosclerosis inside the arteries. How do you do that? How are you going to figure that out, guys? We're going to do an angiogram. What does the angiogram include? Iodine. Okay, you can do the angiogram with fluoroscopy. You can do probably a CT scan, so you can get some really good 3D modeling. Okay, all right. Heart failure. This person's had a heart attack. Okay, all righty. So then you have these categories of drugs. Beta adrenergic blockers. Okay, so you're blocking adrenaline's ability to activate beta adrenergic receptors. Okay. And that is going to slow down the heart because the heart's going because that's the reaction to the poor blood flow. We have calcium channel blockers. That's what these guys are right here. Verapamil, diltiazem. Okay, digoxin is another one that is used. That it actually will depolarize the cell. Okay, and so there's. Anyways, the bottom line is you have these rate controlled drug choices, okay? Then you have rhythm controlled drug choices, and you're categorizing, okay? They have a normal left ventricular flow, or they have an abnormal left ventricular flow, okay? the ejection flow right here, as we're talking about here, and then they're going to add these drugs. And there are all these weird, bizarre, kind of selective or not selective channel blockers. Most of them block potassium channels, but some do others. All right, so I just wanted to show you that because that's kind of the strategy. What do you need to know for the exam? Rate and rhythm control. That's where you're at. Okay, let's go back to our friend. Okay, which is right here. Boom. Okay, so now we can look at one of the tests you're going to run. Okay, so being an electrophysiologist is a big part of being a cardiologist, or maybe someday you're just going to be a clinical electrophysiologist and be part of the team. Let's say, you know what, you had shitty organic chem grades and you didn't get into medical school, but you could still do something like this and be part of the team. And that's what I want you to understand. All right, so let's continue on here and we'll go right in and check out this readout of atrial fibrillation so you'll know what it looks like. It's long. We're not going to necessarily watch the whole thing.
Atrial fibrillation, or Afib, is a heart condition that causes the heart to race and beat in an irregular rhythm. People often say that when they have an episode of Afib, they feel as though a fish is flopping around in their chest, or that their heart feels like it will explode. Afib can increase your risk of heart failure, stroke, and even death. Because of these risks, and because Afib can get worse over time, it is important to have it diagnosed early and cared for.
So you see that how the heart's going flopping all the way. It's not bump 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 bump. Okay, it's beating really really fast, and the rhythm of the atrium and ventricle is completely out of whack.
Appropriately. Afib is the most common type of irregular heartbeat or arrhythmia. It affects over 2.5 million people in the United States alone. Your heart is a muscle that acts like a pump. With each beat, it squeezes or contracts to push blood to the rest of your body.
Right there.
Your heart has 4 chambers. The 2 upper chambers are called atria. The 2 lower chambers are called ventricles. Under normal conditions, the upper and lower chambers of the heart work together to pump blood throughout the body. The bloodstream enters the atrium where blood is pumped to the ventricles in a regular and coordinated way. From there, blood is pumped from the ventricles to various parts of the body. A healthy heart beats in a regular, steady rhythm or pattern. Notice how the heart beats evenly and uniformly. In a healthy heart, electrical signals travel through the heart in a regular pattern, as seen here. These electrical impulses originate in a special section of the atrium and travel through the heart in a regular pattern.
That's the sinoatrial node, okay? And it's right there where the pulmonary vein comes in.
Each signal ultimately causes the heart to beat. In Afib, the top 2 chambers of the heart, or atria, beat very fast and in an irregular pattern that is out of rhythm. Notice how the atria appear to quiver and are uncoordinated. Due to this irregular pattern, the atria do not coordinate with the ventricles, and the heart is out of rhythm. Afib occurs when electrical signals start in the wrong place and misfire. The faulty signals cause the atria to quiver and not contract completely. Notice how the signals spread in a rapid, disorganized way.
You see all those squiggly lines going all over the place? That is ultimately where you're going to put in an ultrasound probe or a cold probe that will actually cause an ablation of those areas so that the electricity won't flow in that direction, okay? It works. Is it perfect? No.
Your doctor may perform a test called an electrocardiogram or an EKG to see your heart's electrical activity and rhythm. During an EKG, small electrodes are placed on specific parts of your arms, chest, and legs using small stickers. When the heart beats, the electrodes send signals to the EKG machine. The EKG measures.
So you can see the bottom AFib. It's all over the place, okay? The electricity is, instead of being quiet in between the regular rhythm heartbeats, it's all over the place. And you can see, for example, here, 2 beats going boom, boom, like that, you know? And then all those squiggly lines reflect the electricity flowing across the atria in a fluttering kind of way. Okay, so we got to get rid of that. You got to get rid of that abnormal electricity.
The electrical impulses or waves shown here as lines. See the differences between a healthy heart and a heart in AFib? In a normal heart, beats are evenly spaced and show a regular pattern. In AFib, the waves appear more chaotic and random.
Rate and rhythm.
While the causes of AFib are often unknown, there are a number of things that increase the chances you might get it. Some of
all the usual suspects.
These include age, family history, smoking, high blood pressure, or hypertension and obesity. Also, if you have any of the following conditions, you're more at risk of AFib, heart failure, diabetes, or coronary artery disease. The more of these risk factors you have, the more likely it is you might experience AFib. Be sure to discuss your full medical history with your healthcare provider. AFib often gets worse as time goes on. It's important to take care of it early because the longer your heartbeat is out of rhythm, the harder it is to return to normal. In this chart, the red lines represent AFib episodes, and the blue lines represent times when the heart is in rhythm. When many patients are first diagnosed, they experience periods of AFib that may come and go. These episodes may be momentary or last for days, but generally go away on their own. This is called paroxysmal AFib. In some situations, AFib may not go away on its own.
So it shows you this progression. Okay, why is it? Because you're having this constant, every time you have these episodes, it remodels. It remodels. So the heart becomes just that much more out of whack because of the way the fibers, the dendritic fibers leaving the nodes are remodeling.
Your doctor may need to perform a procedure or provide medicine for a cardioversion to bring your heart back to normal rhythm. This is called persistent AFib. In some people who have had AFib for a long time, the heart may not be able to return to a normal rhythm at all. This is called permanent AFib. Notice that over time, the red areas are larger and more frequent. This is why it's important to talk to your healthcare provider to be sure that you're doing all you can to keep your heart in rhythm. There are many signs and symptoms of AFib. Many describe an uneven, flopping, or racing heartbeat. AFib can make you feel lightheaded, dizzy, or even short of breath. Some people feel tired.
That's because your blood's not flowing. It's not leaving the heart. It's just regurgitating within the heart. And it's got to come up here, all right? It's got to go through here, all right?
Tired or weak. Others experience chest pain or discomfort, such as palpitations. These symptoms might be subtle or severe.
No blood flow to the coronary arteries, all right? So then all of a sudden the heart muscle is starved of oxygen and it's starting to die off.
And they may come and go, and you may not experience any symptoms at all. In fact, 60% of patients don't even know when they're having an AFib episode. If you have AFib, it's important to know that while you may not feel symptoms all of the time, your heart may still be out of rhythm, and you're still at risk for other complications like remodeling or stroke. If left untreated, AFib can change the size and even the shape of your heart through a process called remodeling. Remodeling can cause permanent changes in your heart in a very short amount of time, potentially just a few days. Because of AFib, your heart has to work much harder, and heart tissue can be damaged. Notice how the heart increases in size and its walls thicken. Even if you're currently being treated for AFib, it's important to understand if your management program is addressing all.
And you can pick that up with a CT scan, all right? And in that way, you can then categorize how progressive the problem is.
The risks associated with the disease. During AFib, blood can collect or pool in your heart and cause a clot to form. If this happens, the clot can travel from the heart to the brain and cause a stroke. If you have AFib, you're 5 times more likely to have a stroke than someone who doesn't have it. It's important to talk to your healthcare provider about your risk of stroke and how to reduce it. You may feel exhausted and weak as a result of your heart not pumping properly. While some people with Afib may be able to lead a normal lifestyle, in some cases, having Afib can keep you from enjoying exercise and everyday activities. If you have Afib, you're 4 times more likely to end up in the hospital 3 or more times than those who don't have the disease. It's important that you continue to talk to your doctor about managing your Afib, even if you are not currently experiencing symptoms. The Afib treatment guidelines for healthcare providers recommend a comprehensive approach to treating all the risks of Afib.
What do we see there? Stroke prevention, anticoagulation, antiplatelet, rate control. All right. So that's instead of having 60 beats per minute, your rate is at 150 beats per minute. So we're going to slow that down. Okay. Beta blockers. Okay. Maybe some calcium channel antagonists, and then we're going to reset the rhythm. Okay. And these are things like digoxin and some of these other potassium channel blockers.
The guidelines prioritize 3 treatment goals: rate control, maintenance of normal rhythm, and stroke prevention. Healthcare providers may provide a range of treatments to jointly manage the different risks and symptoms of Afib. There are a number of ways that Afib is treated. Your doctor may prescribe a medication to slow down the pace or rate at which your heart beats. Notice that the rate medication slows down the heart rate. However, the heart continues to beat irregularly and out of rhythm. Rate control medications do not correct the irregular heart rhythm associated with Afib. They slow the heart rate down, but don't address the irregular rhythm or pattern of Afib. Your doctor may recommend a treatment designed to more specifically address the rhythm of your heart. When rhythm control medication is used, the heart beats in normal rhythm, but remains fast. Rhythm treatment regulates your heart rhythm, but may have little or no effect on the rate at which your heart beats. Combination of rate and rhythm control treatments may be recommended to reduce the heart rate and maintain the normal heart rhythm. Rate control medication is used to slow the heart rate down. When rhythm control is added, the goal is to have the heart beat at a normal rhythm. Other treatments for Afib may include surgical and non-surgical procedures and implanted devices. If medicine has not been effective,
So we see going from drug therapy, which was considered a little bit more aggressive therapy, cardioversion, to a little bit more aggressive therapy, which is catheter ablation. We can have surgical ablation and then pacemaker implantation.
your doctor may perform a procedure called a cardioversion, in which electrical current is used to restore a normal heart rhythm. Radiofrequency ablation, sometimes called catheter ablation, is a procedure that stops the heart from setting off the faulty electrical signals that cause the chaotic heartbeats of Afib. Surgical ablation is a surgical procedure to destroy the cells causing abnormal heart rhythm. It may be used when other treatments have not worked. The surgeon treats the surface of the heart directly rather than relying on catheters and X-rays to reach the heart. For some patients, a small battery-powered device called an atrial pacemaker may be implanted under the skin to generate electrical signals to regulate heartbeat. Talk with your healthcare provider about.
Awesome. So that's pretty much everything you need to know from that video. And so you can see this if then, okay? And this, again, you're looking right here at the risk factors that are associated with it, okay? Here's some really cool reading all about Afib, who gets it, who doesn't, what are the risk factors, so we can see here that it's really common if you've just had coronary bypass surgery because you had a clogged artery, okay, that could not be fixed by some type of catheter removal of the clot, okay, so and then you go from there into different types of conditions that make it much more risky for you. All right. We even see things like high CRP right here mentioned. Okay, so yeah, so this is just a cool reading that tells you what's happening here. All right, we'll go from there, and we look at this kind of downward spiral, okay, a self-fulfilling problem in terms of how that AFib progressed, from paroxysmal all the way to persistent, okay, and then permanent. All right, so then we have what happened here is you're not getting adequate filling, okay? You have dysregulation in terms of the firing pattern that's mediated by calcium. You're going to have a release of adrenaline that's going to increase the rate, okay? And all these changes cause your heart to change its size. So we see the left atrium increases in size. You get this remodeling. The next, you know, the ventricle's getting really thick, okay? And the whole time, because of all these problems, you have reduced cardiac output, okay? Which means that you're going to have less blood flow. That's going to increase your heart rate because your sensors up here in your carotid say, "Where's my blood?" And you combine all that, and you're not getting good flow out to the coronary artery either. And so then you start to have heart failure, and then things just get worse and worse and worse. Okay, awesome. And this right here shows you associated things you'll be able to measure, and this would be the rate, the rhythm. And then you can do analysis of regurgitation and valve problems. Okay, and remember, for that, you do the echocardiogram, which is a form of ultrasound sonography. Awesome. You guys are so on top of this. Okay, we watched our friend undergo the cardioversion. Remember, he was sedated. Okay, and these are two really cool videos that look at this process of, as we're now going from more aggressive, less aggressive to more aggressive. So we are going to, I want to go back up here. Okay, we're going to now look at catheter ablation of the hotspots. So I should actually just take this guy right here. I'm going to copy it, and I'm going to put it over here just to remind you where we're at, okay? So we did cardio, so we did right here, we did rate and rhythm control, and then we did cardioversion, okay? So we'll just bold like that. And then right here, we are looking at catheter ablation, okay? All right, so bold that and that, okay? All right, cool. All right, so again, this shows you how it's done. I'm just going to, a couple of these videos are long, but it gives you a real feel of what it's going to be like when you guys practice medicine, which is what I'm trying to prepare you guys all to do. Okay, a bug. All right.
This video provides an overview of circumferential pulmonary vein radiofrequency catheter ablation for atrial fibrillation. This video is a supplement to the JAMA article, Catheter Ablation Therapy for Supraventricular Arrhythmias by Joseph E. Marine. Atrial fibrillation is the most common sustained arrhythmia affecting over 2 million people in the United States. Symptoms may include palpitations, dizziness, chest discomfort, fatigue, and shortness of breath. Atrial fibrillation is also an important cause of stroke. Multiple factors may trigger atrial fibrillation in susceptible individuals, including premature atrial depolarization and focal atrial tachycardia originating in the pulmonary veins. Circumferential pulmonary vein radiofrequency ablation disrupts transmission.
Tachycardia, really high heart rate. Bradycardia, really slow rate.
Of electrical activity from arrhythmogenic foci in the pulmonary veins. Other mechanisms by which the procedure may prevent atrial fibrillation include ablation of autonomic ganglia, which are located near the ostia of the pulmonary veins, and disruption of sites of micro-reentry. Although the best results of ablation therapy are obtained in patients with paroxysmal atrial fibrillation, this strategy is also commonly used for the treatment of persistent atrial fibrillation. A three-dimensional reconstruction of the heart is generated from cardiac computed tomography or magnetic resonance imaging data using electrical anatomical mapping software.
CT or MRI, okay? And we're going to watch a couple of physicians actually use the 3D data to place the electrodes as they're going to can illustrate with model here.
Once in the electrophysiology laboratory, vascular access is typically obtained through the femoral vein. The right internal jugular vein is
different than the femoral artery. Remember when we were looking at that one approach for actually suction ablation of the clot? They went through the femoral artery, okay, straight up into the carotid. You went through the aortic arch right here. Here you're coming through the femoral vein, which will take you right up back into the heart, so you don't have to go up into the aorta.
Is sometimes used as an alternative. A diagnostic multipolar electrode catheter is placed into the patient's coronary sinus to permit pacing and recording of electrical activity in the left atrium. 2 transeptal punctures are performed and sheaths are advanced into the left atrium.
So you want to have this online recording because you're going to go up there and you're going to fry a couple of spots in the atrium, and you want to see if you'll get a return in rhythm and rate by doing this type of procedure.
A hollow injecting catheter is placed into each of the pulmonary veins, and contrast is injected to outline the size and shapes of the veins. Fluoroscopy is used intermittently throughout the procedure to guide catheter placement, access to the left atrium, and
hitting it with iodine and fluoroscopy, which is an X-ray machine, remember, with 2 sets of panels that are like this, so you can get all kinds of different images that are online as you're doing the surgery.
Manipulation of the mapping and ablation catheters within the heart. An ablation catheter is introduced and used to tag a series of anatomical reference points on the posterior left atrium and the pulmonary veins proper. These points together create a basic anatomical outline that is then used to register the true anatomical position of the catheter within the 3-dimensional reconstruction generated from the patient's CT data. An assistant at the computer workstation integrates this basic outline with the 3-dimensional reconstruction, subsequently allowing the
and we'll show you this assistant in the subsequent surgery. All right, so it's a team in there that is going after this.
Operator to navigate inside a virtual shell of the patient's left atrium. Now navigating inside the 3-dimensional reconstruction, with occasional reference to fluoroscopic images, the operator performs a series of point ablation lesions in circles outside the pulmonary veins. This is primarily done using anatomical references, although the electrogram from the ablation catheter itself is monitored. Point ablation lesions can be applied in any sequence, but typically, a large ablation ring is first made around both the left superior pulmonary vein and left inferior pulmonary vein, followed by another large ring around the right superior pulmonary vein and right inferior pulmonary vein. Data points are added onto the 3-dimensional reconstruction display as the procedure progresses. After the initial ablation circles are completed, the circular mapping catheter is placed sequentially into each of the pulmonary veins to check for electrical isolation. The circular mapping catheter is comprised of electrode pairs that detect electrical activity at specific locations recorded on an electrogram. If the electrogram shows residual electrical connections between the vein and the left atrium, then additional radiofrequency current is applied at these sites.
So
on the electrogram, sudden loss of electrical activity.
You're trying to isolate this abnormal discharge that is originating in these veins as they enter the atrium from the actual atrium proper. All right, cool. So you get a feeling of how awesome that is. All right, so now let's go ahead and go back here to the actual surgery, and you can see the image that I've selected there, where they're using the 3D reconstruction from the CT, combined with fluoroscopy that was online, and then you'll see down below on the very bottom part of this image right here, you can see the electrophysiological recording that they're doing ongoing. Remember, with the circular electrodes. All right, so let's check this out. And we're not going to watch this whole thing. All right.
So here we are in the EP lab getting ready to perform ablation for atrial fibrillation. We have the patient on the table, nurse giving final instructions, going off a checklist, anesthesia getting ready. We describe to the patient one more time what we're trying to accomplish, emphasizing our priority for safety as well as a very efficacious procedure that is very effective for the patient. So we're going to do as good a job as possible, be as careful as possible, and have a durable clinical result. So
Okay, cool. So now we're going to advance here.
transeptal sheath and ablation catheter. In the heart, whenever we move the ablation catheter, we recreate three-dimensional geometry of the heart. So here we're reproducing right.
You see the electrophysiology on the bottom, the 3D geometry generating online from the fluoroscopy as they're hitting it with iodine, okay? And then we'll see that they'll match that up then with former CT scan data and superimpose everything. It's pretty cool stuff.
Sided structures, recording the His potential, marking the tricuspid valve annulus, very important for us, advancing the ablation catheter deep out the coronary sinus, incorporating that structure into the map that wraps around the left atrium, gives us a very important anatomic landmark that will guide our procedure. And having created that tricuspid valve to the right ventricle, now looking at the left ventricle, we see again the function of the left ventricular chamber, the valve structure. Importantly,
so that would be an echocardiogram right there. So they're monitoring the heart and the valves.
Confirming no effusion or fluid buildup between BRK needle to engage the interatrial septum. The needle comes out, the sheath and dilator go over the needle, then the dilator needle complex come back, leaving the sheath unopposed in the left atrium. And this is what, so confirming that we're properly orientated, we'll see bubbles forming in the left as we desire. Here is the ablation catheter advancing through that transeptal sheath into the left atrium.
So the one lecture on the right is for ongoing recording, and the other one is now you're going to put in the radio frequency ablation tool that will just create these little hotspots because the high frequency radio waves will actually burn and kill off some of the desired tissue right where the pulmonary vein enters the atrium.
We will curve that catheter in the heart to anchor the position of that catheter for our second transeptal puncture, which we'll need to perform before we start our procedure. So there is that solid structure, that's the sheath adjacent to our first. Here we are dropping into position. We'll advance this pentarray, this 5-spline catheter through that sheath. That is our mapping catheter, very electrically sensitive splines. And here we see two catheters crossing the interatrial septum. Those are those two solid structures in parallel, one being the ablation catheter, one being the mapping catheter. Both are crossing the interatrial septum, entering the left atrium, and importantly directed towards the left pulmonary veins, which I'm pointing to there.
The mapping catheter is all about mapping the electrophysiological activity. Okay. Awesome. Now we're going to get into the 3D analysis real quickly here. All right.
Or we manipulate that pentarray catheter, that mapping catheter in the left atrium, reproduce the 3D geometry of the left atrial structure, comparing it to a CT scan of the left atrium that we had acquired pre-procedure. So we
have the CT scan, ongoing fluoroscopy, electrophysiology. It is so cool that this is all happening online while you're doing the procedure.
Fully develop and create a 3D representation of the left atrial chamber, the body of the chamber, and then the 4 pulmonary veins that insert into the left atrium, which we are going to be ablating around. So there you see the pentarray catheter coming out the left superior pulmonary vein, creating that particular structure, mapping.
And there's the technician, okay, that he is highly specialized in this radio frequency ablation and the electrophysiology side of things, okay. We also have the associated nurse in here. Okay, so it's a whole team inside this operating room.
Experts in the control panel as well as our own staff guiding us through the procedure, helping us to perform at every stage. Now that we're all set up, the environment becomes quite zen. There is anesthesia monitoring the patient. The patient is very stable, completely. We call this pulmonary vein isolation. So with radio frequency energy, we are going point by point around those veins to completely electrically silence them. And this is the backbone of any ablation procedure, the live electrical recordings from the throughout the left atrium. It's a very healthy chamber. Those green patches.
Here they're testing it. So anyways, I just want to give you a feel of how it's all put together. All right, guys. let's continue our march through this, okay? Alrighty, so that's one approach, okay? Now, we also, in terms of preventing a stroke, okay? So we have done everything in terms of this really common cause of stroke. It's an embolism of cardiac origin that's coming from atrial fibrillation, some type of arrhythmia, okay? And the clot forms, it breaks off, and then that is an embolism that goes up to the brain, and then that will cause an ischemic stroke, okay, as it blocks the artery. All right, well, let's now focus in on our carotids, okay, and what we can do about the carotid artery. So we're going to look at balloon angioplasty and stents, and then we will follow that up with, again, starting conservatively, okay, and then getting more aggressive, right? So we have moved past Afib, and we're now going into surgical procedures to deal with carotid problems, okay? Okay, so this is just a model that shows how this angioplasty and stenting works. This is actually a combination of the model that actually shows if you can kind of dart back and forth with your eyes, not only the model but also the an ongoing surgical procedure. All right, so let's check this out. All right, friends. Okay. Yes, Julie. No, it's all good. It's all good.
So here we are in the EP lab getting ready to perform ablation for atrial fibrillation. We have the patient on the table, nurse giving 5.
Just grabbed the wrong one. Okay, hold on a sec. I thought I grabbed it. That's the one we just looked at, isn't it? Okay. All right, so let's see. Unless I could have messed up. I hope I didn't do what I think I did. But let's see here. Control C. Okay. I hope that's not the same one. No, it isn't. Okay, good. All right. Sorry, guys. Okay, this is more like it.
Carotid arteries are located on each side of the neck and extend from the aorta to the base of the skull. These arteries supply blood to the brain.
We're going to look at a combination of balloon angioplasty. Okay, again, now we're going through the femoral artery, all right, up through the aortic arch into the carotid. Okay, we will break up the plaque that is right there where the external and internal carotid bifurcate. Okay, with angioplasty, and then you will then insert a stent. The idea of the stent is a wire mesh, and it will then be this framework so that it won't collapse or form new a new giant plaque in your carotid. Problem is, you still get what's called re-stenosis, where the plaque forms and it comes in. So these things are not permanent.
There is one main carotid artery on each side of the neck, and each of these divides into two major branches, the external and the internal carotid arteries. The external carotid supplies blood to your face and scalp. Your internal carotid supplies blood to the brain. Buildup of plaque in this artery is called carotid artery disease. In some cases, clots may form on the plaque as well. If a piece of this plaque or clot breaks off or embolizes, it can enter the blood vessels in the brain. The result is often ischemic stroke, which can cause brain damage, leading to serious disability or death. The result is often ischemic stroke, which can cause brain plaque as well. If a piece of this plaque or clot...
You can see the open blood vessel on the left and the occluded blood vessel on the right, okay? That would be CT angiography. I just wanted to show you that, all right?
Breaks off or embolizes, it can enter the blood vessels in the brain. The result is often ischemic stroke, which can cause brain damage, leading to serious disability or death. The procedure takes place in the cath lab. The patient is awake and alert. A local anesthetic is applied to numb the catheter insertion area. Then the narrow areas of the arteries are located by injecting dye and reviewing live x-rays called fluoroscopy. The dye does not allow x-rays to pass through, so the physician is able to clearly see arteries and uses the live x-rays to guide them to the blockage. Through a needle puncture in the groin or arm, the doctor inserts a catheter guided to the...
Remember we watched it earlier for the endovascular surgery when I was reviewing fluoroscopy with contrast? So now we're watching it in terms of stenting and balloon angioplasty, okay? Endovascular, though, is the procedure, okay? It's an endovascular procedure of stenting and balloon angioplasty.
Location via fluoroscopy. Next, a small wire with a filter near the end, similar in appearance to an umbrella, is placed beyond the blockage. This embolic protection device, or EPD, is inserted to catch clots or debris that may break away from the plaque during the procedure and cause stroke. The physician then widens the blockage by inflating a balloon at the site of the blockage. Using another catheter, the physician guides a compressed stent to the same area in the artery. A stent is a mesh tube that is expanded in the artery, keeping the walls more permanently separated. Once the stent is in place, the physician releases it. The stent then expands to fit the artery. A balloon catheter is once again introduced to further expand the stent. The entire procedure typically takes under 1 hour.
You can see the catheter right here ballooning out. You can see the stent, the halo of the wire mesh. Again, this has come right up to your carotid.
The results are immediate.
Boom! Awesome. Very cool. They were immediate, weren't they? Okay. All right. Let's continue on, guys. All right. So that was carotid artery stenting. It's an endovascular surgical procedure. Okay. Starting through, the femoral artery. You do a balloon angioplasty, followed by a stent, and then a second balloon angioplasty. Okay. All righty. How about carotid endarterectomy? This is where the plaque is too big. Okay. You can't use a stent. You cannot do a balloon angioplasty. So now you got to go cut open the carotid artery and you got to remove it. Okay, not the artery. You got to remove the plaque. So remember, this is your carotid artery right here. We can show you a real quick one right here that again shows you the model along with the surgical procedure. And then this is a really long video. This one right here, it's so awesome. We may watch it together later. I'll show you the hot spots.
Your doctor may recommend you get a carotid endarterectomy if your carotid arteries are narrowed or blocked with plaque. In your neck are two major blood vessels called the carotid arteries, which carry oxygen-rich blood from your heart to your brain. You can feel the pulse of the carotid artery.
The symptom would be you're fainting, lightheaded, dizzy, all the above. Okay, you do the analysis of the heart. Heart's fine. Okay, not Afib. Then you go up, you do some imaging, and you go, oh boy, we got to get rid of that.
In the side of your neck. Fatty deposits called atherosclerotic plaques can build up inside the carotid artery. These plaques can narrow the passageway of the artery and interfere with blood flow to the brain.
Remember how it all started, guys? Remember? Little tiny tear, okay? Maybe some cigarette smoking being an irritant to the endothelial cells that causes them to pull back. What else do we have? We have, homocystinuria, so you have a little too much homocysteine in your blood, okay? Irritates the endothelial cells, they pull back, okay? Oh man, there it goes. And then it generates that whole inflammatory response. Remember, we talked about that? Endothelial cells releasing cytokines, cell adhesion molecules, okay? In comes the monocytes to become macrophages. You have an underlying condition of high LDLs. They get oxidized, triggering more activation of receptors that lead to more inflammation. You're diabetic, okay? Age activates rage, all this stuff, and now you're looking at it. You're looking right at it, guys, okay? This is a chronic condition that's evolved over maybe 20 years in your patient.
This blockage or narrowing is called a stenosis. If blood flow to the brain is blocked temporarily, a transient ischemic attack, also known as a TIA, may occur. When the blood flow is completely obstructed, as in a carotid artery blockage, a stroke can occur. Before your procedure, an intravenous line will be started. A carotid endarterectomy is usually done under general anesthesia, which will put you to sleep for the duration of the procedure. In this case, a breathing tube will be inserted through your mouth and into your windpipe to help you breathe during the operation. Sometimes a carotid endarterectomy is done with local anesthesia. If local anesthesia is used, you will remain awake, but your
Just kind of mind-blowing when you watch a procedure.
neck will be numbed. You will probably also receive some sedation.
Yes.
On the side of your neck along the blocked artery, the surgeon will make an incision that may run from just behind the ear to a point above the collarbone. Your surgeon will find the carotid artery and temporarily clamp off blood flow through it. Your surgeon will
So you see live on the right where they've actually got in there. So now they're in isolating the external internal carotid, and you'll watch them actually as the model is going on the left, the actually live version going on the right.
open up the artery and may place a shunt or temporary bypass to keep blood flowing to the brain.
It just depends how quick it is. Okay, if you can do this quickly, you don't have to do the bypass. Remarkably, if you can get this removed and sewn back up, you release the clamps. If you can do that within say about 10 minutes, you're good to go. All right, but it just depends on the patient. Sometimes they do the shunt that will shunt blood around what you're doing your surgery. See on the right?
Your surgeon will then remove the plaque within the arterial walls.
Pretty incredible.
After the blockage has been removed, he or she will sew the artery back together, usually placing a patch to widen the artery slightly.
Yeah, so you can use a vein that you splice out or an artificial membrane. This one right here is really long, but I want to show you the really cool parts. Okay, well, I think we can watch this together and pass out from the gore. But before we do that, I just want to watch it, show you the highlights of this one, because it's the same drill, but it's just pretty remarkable to watch it happen.
In this video, we will demonstrate a routine left carotid endarterectomy. The speaker is Dr. John Eit, Chief of
All right,
that you have all available imaging, so pre-inject with lidocaine.
Lidocaine.
Step 3 is to expose the medial border of the jugular vein.
So you got to just slice your way through. All right. Now what they're doing is isolating.
We then continue the dissection in a slightly deeper plane, dividing the soft areolar tissue between the jugular vein.
You don't want to cut
as close to the carotid artery as possible.
All right, there we go.
Step 5 is anticoagulation. We usually anticoagulate as we get down close to the carotid bifurcation.
You don't want somebody throwing
Step 6
a clot
to provide
while
vascular
you're doing
control.
this thing.
We usually put a vessel loop around the superior thyroid artery and then around the external carotid artery, as well as around the internal carotid artery and the common carotid artery. In this case, we've used a umbilical tape to use as part of a tourniquet if a shunt is needed.
All right, cool.
Artery, and then the common carotid artery and the external carotid.
It said if a shunt. So they just kind of play it by ear on how long this procedure is going to be, whether or not they're going to shunt the blood around the surgical area.
11 blade, and then we extend the arteriotomy up through the plaque and down into the common carotid artery, into a soft portion of the carotid.
It's kind of mind-blowing.
You can see the stenosis here at the origin of the internal carotid artery. In this case, this was a web-like deformity. Step 8 is the actual performance of the endarterectomy itself. We usually use these delicate forceps to develop the planes rather than using a freer dissector. And we start in the common carotid artery, and then depending upon the situation, I may extend this up into the internal carotid initially, but eventually get circumferential control of the common carotid.
Common carotid, internal, external carotid. You see, this thing is huge.
And then divide the plaque
all started with that
squarely
to
the proximal end of the arteriotomy, making sure not to leave any loose flaps. We then extend up to the external carotid artery and do an eversion endarterectomy of the external carotid artery.
They're just going to, meaning pulling it out.
and then remove the plaque in its entirety.
Amazing.
You can see when we get the plaque out, we've got a good external carotid endarterectomy.
You see both the external,
and you
internal,
can see
and
the
carotid
stenosis here at the distalmost portion.
The remaining part
And then
is
inspect the endarterectomy
sew it
and make
back
certain
up,
that we've got a good,
which we don't need to watch, but I just wanted you guys to get a feel of everything we've been building up to this point in the semester 4, okay, which I think is pretty awesome. Okay, awesome. Okay, alrighty. So we've done our surgical procedure there. Okay, we have an active stroke. Okay, so this is done. All these things that we've done here, this is all preventative at this point in time. But now we got to have an active stroke. Okay, what are we going to do? Right. So the key element here is first pass. If you're EMT, emergency medical technician, okay, if you're in an ambulance, you can tell somebody's having a heart attack or stroke. You're going to give them intravenous tissue plasminogen activator. Okay. The drug's called Alteplase. It's synthetic, okay, and we have circulating plasminogen made by the liver. Thank you, liver. Okay, and so when you make your clots that we've gone over before, the intrinsic and the extrinsic pathways. Okay, so remember tissue factor, okay, being released by everybody under the sun, and then this is collagen mediated here. This is the more active one right here. We have all these different drugs that you can give to stop it. Warfarin we talked about, okay? Factor 10 10A inhibitors. Remember that was Xarelto. Johnson & Johnson, $1 billion, okay? And then we have the heparins, okay? And so these are going to reduce the likelihood of the clot we talked about before. But here we are. The problem is the clot is here. The fibrin has been deployed. Okay, you get nothing but fibrin all over the place, intersecting with the platelets. So we can give you tPA that will take this plasminogen and accelerate its formation in the plasmin, and plasmin cuts the threads and gets rid of the clot, okay, releases the platelets, all right? So this is what you do, you have 3 hours, okay? So the idea is the first 3 hours is crucial after a stroke in terms of tPA therapy. All righty, so this again is the model showing you exactly what I was just talking about. So we look right here, and I know you're getting double vision, but I can't help myself. All right, so we have tissue plasminogen activated that you've just infused. It's also, again, this is naturally produced in our bodies as well. It will activate plasminogen, turn it into plasmin. This is the thrombus right here. And you see it's dissolving it. It's chewing it up and it dissipates. Okay, this is like time lapse going left to right. Okay, all right, and we can watch right here kind of a animation real time of what this looks like.
Activase, also known as recombinant tissue plasminogen activator, or tPA, is the only drug approved by the FDA for treatment of stroke. Growing plaque can rupture, promoting thrombus formation, by activating the coagulation cascade. Platelets and red blood cells aggregate at the site of injury, causing further narrowing of the artery. This impedes blood flow even more and causes turbulence in the artery. It also
and then on top of the platelets and red blood cells, the fibrin, okay, from extrinsic and intrinsic, okay?
increases the likelihood of thrombus formation. As the thrombus grows, it causes increased vessel narrowing, leading to partial or even complete occlusion. The occluded artery leads to ischemia and tissue necrosis. When a piece of thrombus breaks off, it's called an embolus as it
There's the embolus I was talking about.
Travels up the artery. During a stroke, ischemia can progress to infarction. Beyond the infarction,
so the infarction is a complete occlusion, as you can tell by on this side versus this side.
lies still viable tissue called the penumbra. Cells within the penumbra are potentially salvageable if blood flow and vital oxygen are restored properly.
What do they undergo? All right, they're sitting there going, I don't know, am I going to go through apoptosis or not? Remember the penumbra? All right, get in there, man. The earlier you get in there, the better.
The penumbra is the focus of fibrinolytic treatment. Now let's look at the thrombus itself. Inside the thrombus are strands of fibrin, the protein that forms a clot. Enmeshed.
How did that fibrin form? Extrinsic and intrinsic coagulation cascade. Okay, ultimately forming the fibrin threads. All right. Remember all the factors: tissue factor, factor 7, factor 9, factor 10, factor 10A. All right.
Within the fibrin is plasminogen, the inactive precursor of plasmin. Activase is administered by IV infusion within 3 hours of acute ischemic stroke symptom onset. Activase binds to the fibrin in a thrombus and converts plasminogen to plasmin. Plasmin then breaks the strands of fibrin and dissolves the clot. As the clot dissolves, blood flow is restored, and viable tissue may be reperfused. Although the original infarction remains, when surrounding cells in the penumbra are saved or...
All right. What is the original factor? It's the ischemic core. All right. Also the infarct, right? And then the penumbra.
Reperfused, function may be restored. Activase, the 1 tPA for...
Yes, sirree. Okay. All right. So we're almost done here, guys. So that is intervention, right? Intervention, right? What else do we have? We have, you can have an active stroke or heart attack and do endovascular surgery, all right? Remember, with this, you're going to have catheterization, okay? And you're going to come up through the femoral artery, right? And you're going to be using fluoroscopy, all right? And you're going to be monitoring the guiding, the catheter that you're going to use to do the endovascular surgery. Okay, this right here is a video of somebody that is having a heart attack. Okay, and it shows you the same procedure that we saw in the last time. It's really cool, but we don't really have much time for that. Okay, all right. But we'll watch this later. And so I put information here and here that's about what he's talking about in terms of doing the surgery for the heart attack. Okay, and it has to do with the readout that he has in terms of blood levels. Right. All right. Cool. And then this right here is again using endovascular surgical technique. And what they do show in here, and I'm just going to quickly get to it, is they're going to show you that they have a CT scan, and how the CT scan doesn't really pick everything up. They do the perfusion CT, and it's clear. It's clear that there's been a significant stroke, right? All right, and there's something that we talked about earlier in terms of the diagnostics. We're just going to advance to that part of the video, okay?
Hi, I'm Peter Mitchell from Radiopedia.org, and in this last episode of our stroke series, we will be discussing endovascular intervention on ischemic stroke.
Right. So this is the
in 2012,
they use right
a new type of device became available,
surgery,
Solitaire,
one or the other,
which comprised a relatively open mesh stent attached to a wire, hence retrievable, originally designed for use in treating a 10-year-old male patient presented to our emergency department with a right-sided hemiplegia, which had a sudden onset only 2 hours earlier.
2 hours earlier, all right, he had a stroke, all right? Hemiplegia, he's got paralysis, okay? On the right side, it means it's on the left side of the brain.
The initial non-contrast CT demonstrates
show him advancing through the skull and then getting deep into the brain, right? Non-contrast CT, okay? And you listen to what he has to say.
Demonstrates no evidence of hemorrhage.
No evidence of hemorrhage.
Left MCA, confirmed on CTA as an M1 segment occlusion. There is no convincing grey matter hypoattenuation, an important negative, as loss of grey-white matter differentiation suggests an established infarct.
Yeah, so they maybe have caught it early enough, okay? So that you're not losing brain tissue. There's no differentiation, hyperintensities, evidence of the brain having a major core infarct that's gone.
CT perfusion demonstrated prolonged mean transfer time, but no significant abnormality in cerebral blood volume. This is consistent with a large ischemic penumbra. In other words, most of the area supplied by the now occluded vessel has not yet died, being
so that's crucial, and you can now follow this in the patient, okay? And it's real key in terms of your diagnostic. Awesome. All right, that's all I wanted to show you on that, guys. Very cool. Okay, lastly, this is actually preventative surgery, all right? So this in some ways doesn't belong here. We're talking about aneurysms, okay? Clips and coils. Coiling is the gold standard now. Clip was the old way. So these right here, we're looking at all the places that you're likely to see an aneurysm in the brain. And it's always at the place that has the highest turbulent flow and blood pressure. And it's no different than having a balloon, okay? And you fill it with water, all of a sudden, the weak spot, it balloons out, okay? So that's what happens. You get a weak spot in the vascular tissue. All the endothelium, the matrix of elastin and collagen, and then the overlying smooth muscle cell stretches out, and now it could just rupture at any moment in time. We call them the silent killers, okay? We see that right here it says approximately 85% of the aneurysms develop in this part right here of the circle of Willis, okay? All right. So what are we going to do for that aneurysm, okay? Back in the day, we just go in there and you would actually stick a clip in there and leave the clip in the brain, okay? That was problematic, okay? Then they developed this method because you had to open, full-on craniotomy, take a big chunk of the skull off and go in and do the surgery, okay? That's major surgery. Then they developed what's called coiling, okay? Endovascular, through the femoral artery. It's the bomb, okay? And again, what you do is you fill the aneurysm up. You see the balloon right here. You fill it up with this really flexible element that has plastic and wire, and it fills up the aneurysm, and then what will eventually happen is your body will naturally seal it off, okay? All right, so that's coiling, and this is right here. This is from the Brain Aneurysm Foundation, and they did a study, and it was clear that coiling was superior to performing clipping, because again, the clipping had to open up the skull, and this is just endovascular surgery, right? Control C. All right, so you can see the coil deployed right here, and I'll show you highlights of this video, and then we're done, sort of. Awesome. We're not watching this whole thing. Okay, so neurovascular coiling, okay? All right, so, we have right here fluoroscopy, all right? Went all the way over the aortic arch, okay? Beautiful. Okay, so we're gonna pull it back now, pull it back, okay. All right, now we're gonna guide it up into the carotid. Yeah, that's what you see there. Boom, what happened there? What was that? If that was an exact question, what was that contrast? Fluoroscopy, it was iodine. Poosh, all right? They're going one side carotid, the other side carotid. All right? Now they saw the course of the carotid. Now they know they're going up the right spot. All right, we're going to go up. All right, and there's different stages to the catheter as they place it up there. Can you see the breathing right here? Look at this rib cage, up and down, up and down. How awesome is that, right? So they're positioning there. Here comes the thicker sheath now that's going to follow the guide wire. Here it comes. Bum, 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 bum. All right, very cool. Here comes the sheath. Here comes the sheath. Here comes the sheath. All right, because then they can take the guide wire out and stick the coil up. All right, so that's this thing that you're constantly doing in terms of your procedure. All right, then how are they going to know they're in the right spot? What would you do? All right. So you're going to withdraw the sheath. Boom, that's what you do. What was that? Fluoroscopy, right? And now you have this permanent image, and you can see over there on the left the big giant aneurysm, okay? Alrighty, so now we get a guide. Oh, the catheter up inside the aneurysm, okay? Not there yet. Got to reposition. Oh, here comes the sheath. Awesome. And how is it that we're able to visualize this? Okay, again, there it is. Okay, so now it's a 3D image of the aneurysm. Okay, generated with the fluoroscopy. Now, again, there's a surgeon, but there's always these other people, all right? So you could be this interventional radiology team member doing all this, okay? And you don't need an MD to be this person doing this. All right, now he's just doing analysis, okay? And we don't need to do the analysis. We need to get in there and place our friend up there, all right? All right, so now we're coming back up. And the reason for the balloon, they're just gonna, it just gets you through a clot. They're just trying to isolate the blood vessel where the aneurysm is, okay? Oh, here comes a second probe, all right? So you've isolated the aneurysm on either side, just in case you throw a clot, okay? Look at that, that was awesome. First try, went right into the aneurysm. And now they're just gonna insert the coil. Okay, here it comes, here it comes, here it comes. All right, boom. So you had two sheaths at one time, and then you just put the coil in, right? Pretty amazing. And this goes on and on and on. You just keep threading more and more and more and more and more and more. And you see you completely fill up the aneurysm. So you don't have to go in there and surgically clip it. You don't have to remove a big piece of skull. And this could all be done with local anesthetic. How awesome is that? Okay. And then you're done. You deploy it and you're done. There it is. Okay, now blood is not going to flow into here and burst it. The blow is like a dam, and the blood just goes on the other way, right? So cool. All right, I thought you guys would like that. All right, where are we at now? Here's the review set. Okay, so everybody wants a study guide. Here's your study guide. I did a quick analysis of what we did in terms of diabetes. I thought it was important to have this. Okay. Boom, boom, boom. And then here's even a concept in terms of exam questions. You know, I don't know if I'll throw them on. I might. Okay, so here we go. Then we go into stroke and everything we have done in this class for stroke, including what I just did today. Okay, in terms of the surgical procedures. All right. Whew. All right. So guess what? I'm done, guys. And I hope you had a good wellness day. I'm feeling pretty well, and I'm going to say at that point, peace.